Hi, everybody. Thank you for joining the webinar today. It's going to be on complexities in routine cultures, common conundrums in bacterial identification, and susceptibility testing. I'm Rosemary She. I'm a pathologist and director of microbiology at the Keck Medical Center of the University of Southern California in Los Angeles. The talk today is supported by Rosemary She, and that is my only disclosure. Here are the learning objectives for the talk today. We'll be using several cases to help illustrate the following. First, we'll have a couple of cases on a situation in which rapid identification of a pathogen is central in directing appropriate susceptibility testing workup. And then we'll actually have a series of cases to describe some of the discordant results you might see for methicillin resistance testing in Staphylococcus aureus. And then finally, we'll have a little bit time at the end to review a case of a polymicrobial culture in which synthesis of various pieces of clinical information is really helpful in directing our workup in the microbiology lab. So let's dive into our first case. This is actually two cases, one before implementation of MALDI-TOF and one after. So this is the case from 2014, pre-MALDI-TOF implementation in our laboratory, and this is at the LAC USC Medical Center. So we had a patient, 61-year-old male, who presented with fever, night sweats, and general malaise. The physical exam was really notable on the cardiovascular exam for heart murmurs or systolic murmurs, and distension of his jugular vein that was really evident in the neck. So they proceeded to do an echocardiogram imaging of the heart, in which they saw mitral valve vegetations, which are basically growth or masses on the mitral valve in the heart. So this led them to really consider a diagnosis of, actually presuming a diagnosis of bacterial endocarditis. And of note, this was his native valve. He had not had any prior valve replacement surgeries or anything like that. So the patient was started on ceftriaxone for this presumed diagnosis. So of course, one of the key steps in working up such a case of infective endocarditis is to perform blood cultures. And for this patient, fortunately, his blood cultures flagged positive pretty readily. Both sets in the aerobic bottles flagged positive. And when the laboratory performed the gram stain and the subsequent workup, what they saw were gram-negative coccobacilli, and subcultures were pretty slow to grow and only noted growth to be on chocolate agar, no growth on the blood agar. The organism was fairly biochemically inert, oxidase negative and catalase negative, and identification failed on our biochemical kits in use at that time for identification of organisms, including the Vitek NH card and the REML Rapid ID kit. So this was a very inert organism. We were thinking, we're not sure if we ruled out Haemophilus quite yet, if the oxidase and catalase were just slow or just not reacting on this organism. But haystack organisms are a bit higher on our differential, definitely with the oxidase and catalase results, versus maybe some other of the numerous fastidious gram-negatives that are out there that we'll see rarely from time to time. So this was a case in which our biochemicals were not good enough, and we had to send the organism out for identification at a reference lab. What we could do was a beta-lactamase test, which is frequently done on fastidious gram-negatives, and that was negative. So that's all we had at the time for the clinical team. Now, the clinical team, infectious diseases, was consulted. Their providers were getting a bit, impatient, understandably so, because many days had passed, and by the time it got escalated to myself, what I heard was it's been 3 days, no progress on identification, they don't have susceptibilities, and they became increasingly insistent that we set up susceptibility testing. And they basically said they needed ASAP so that they could decide on definitive treatment for the patient. And this is at a point where now escalated above my pay grade, and they were requesting all sorts of interesting suggestions on how we could set up susceptibilities and they could get the data that they needed. Okay, so one of the suggestions was to perform susceptibilities in every possible manner, so we could give them sets of data that they could interpret themselves offline. To which we stood our ground and very proud that we stuck to our guns and said no. There's many reasons, obviously, for this. Number one is not good laboratory practice in microbiology. So here in this table, I'm just showing you some examples of how both the method and test conditions, and then also the drug panels that would be selected for these various organisms on our differential would be different from each other. So number one, top row, you can see for Haemophilus, there's only standardized guidelines from CLSI for Haemophilus influenzae and parainfluenzae susceptibility testing, not for the other Haemophilus that might be in our differential. For other HACEC organisms, we have different method and test conditions again, and different drugs that would be tested than the Haemophilus. And then for other unknown fastidious gram-negative rod, we have no idea, how we would set up if there's any standardized guidelines and interpretive breakpoints. So that is one issue, just not knowing how to test if we don't have an identification. And the other issue is if that testing is validated or verified in one's laboratory. Certainly not automated instruments, and certainly without an identification, you couldn't even send out an organism to a reference lab to ask for an appropriate susceptibility panel. So we said no, much to the disappointment of some members of the team, whereas others were a bit more receptive to our point of view. But this is what they were seeing, and I totally empathize and understand the frustration. So our beta-lactamase test, which was negative, wasn't terribly helpful in that there's other mechanisms of beta-lactam resistance that won't be covered by our beta-lactamase testing. So that didn't give them that much information. And then there was another piece of information I thought was kind of helpful for both sides to see, and that was the IDSA and American Heart Association guidelines on infective endocarditis, how to treat, how to take susceptibility information into account. Now, if this were a HACEC organism, the guidelines say if you don't have susceptibility testing results available, presume it to be ampicillin resistant. And I'll show you some data on why they provide these guidelines for, to control for the absence of susceptibility test data. So the recommended therapy in those cases is ceftriaxone, which the patient was on. And there are some other alternative treatment regimens provided in the guidelines. Unfortunately, we still weren't definitely sure what the organism was, and treatment for other gram-negatives causing endocarditis would be different from this. Nonetheless, we were able to at least tell the provider, look, we really suspect HACEC organism. We just can't get the biochemicals to key out. And they did maintain the patient on ceftriaxone. They were doing well. They were stable and effervescing on this therapy. Okay, so it did take quite a few days, but in the end, the reference laboratory identification came back good for aggregated bacteriophrophilus. So our suspicion that this was HACEC was definitely correct. And of note, for this HACEC organism, susceptibilities were not validated, verified in-house. So we had the reference lab continue on the workup and perform susceptibility testing. And as I showed you, there are CLSI guidelines on how to do this, and that can be found in the M45 document. Okay, fast forward 2 years. Remarkably, we had an almost identical case present. And what a difference it makes to have a rapid and accurate method of organism identification in the MALDI-TOF that had been implemented by this time. So this is a 58-year-old male with native valve endocarditis, and again, had positive blood cultures with a gram-negative coccobacillus that was fastidious. And that first day off of that positive blood culture, we had by then implemented the molecular gram-negative panel of the Veragene line, and that had no targets registered on the results. So we waited for subcultured colonies to grow, day 2, day 3. And when the provider called this time from the infectious diseases team, we were able to tell them, hang on a sec, we're putting that organism colony on the VITAC MS right now, and we'll have results for you in a couple hours. And we sure did, and it came out beautifully as aggregated bacteriophrophilus. everything was said and done, and the providers knew exactly how to treat the patient from there. So this was a very, very different story. And I thought we had some good learning points from these cases, which we'll go over right now. I think it's really important for labs to recognize infective endocarditis caused by gram-negatives as a special entity. And in fact, HACEC organisms are the most common gram-negative organisms causing infective endocarditis. So from blood cultures, it's really good to know this. Even though they are said to be the most common overall as a cause of infective endocarditis, it's only maybe 5 to 10%. More recent literature and reviews cite slightly lower percentage than that, even 1.3 to 3%. So not terribly frequent. And then starting off back with these cases on the susceptibility testing challenges, as the guidelines recognized, there can be challenges in even getting susceptibility test results to be valid for the HACEC group. And the guidelines are based on a really good study, which I'm summarizing really quickly here, from 2013. They looked at 174 HACEC isolates, which is quite a few, and found that the majority of them did not grow adequately for susceptibility test purposes, even after 2 attempts to get valid results. So just the growth was not adequate. And notably, this seemed to be more prominent with Haemophilus parainfluenza, for which 33% had only 33% success rate. And the other HACEC organisms had a range of more like 60 to 83%. So that's just good numbers to kind of keep in the back of our heads when it comes to getting these test results back. And then going backwards now to the identification, some learning points here for the HACECs. I don't think I need to tell anyone in the audience that we know they're not the most frequently encountered organism in the microbiology lab relative to our E. coli and staph. So we're going to have inherently less experience with these organisms, identifying them and performing susceptibility testing, if at all. The differential for them can frequently involve other fastidious gram-negatives, which we also encounter less frequently in the laboratory. So overall, we're just less familiar with these organism groups as we are with others. So these are just inherent difficulties in identification. Back before MALDI-TOF, we struggled when they were biochemically inert and didn't grow very well, or just didn't give us enough information off of our biochemical kits. So that's always been a challenge with the HACECs. Okay, and yet, as I showed through these cases, having that accurate organism identification is really necessary in order for us to proceed with the appropriate susceptibility test method. So getting that identification accurate, I thought it was, we had a really nice study that I looked at back from 2013. So granted, it was 10 years ago prior to the MALDI databases having undergone several updates. But anyway, they looked at, again, an incredible number of HACEC, as far as HACEC goes, 140 isolates, and compared 2 biochemical kits, which we actually talked about in the cases, the rapid ID kit, the Vitek 2NH card, and the Vitek MS MALDI-TOF. And back then, they had to use the Ceramis database, but this was with the direct MALDI setup method. Okay, and you can see that the correct species ID was lowish, 60 to 77% by biochemical card, compared to the MALDI, which was a bit higher at 86%. So still some challenges, but some improvements with technology. And then for any of us that are doing, since this was blood culture case here, doing rapid MALDI-TOF off of a rapid 5-hour plate incubation, that method's been looked at with fastidious gram-negatives, including HACECs. And as expected, with only 5 hours of growth on the subcultured plates followed by MALDI, you're not going to get great growth with our fastidious gram-negative bugs. And the success rate was only 36%, although they only had 14 isolates in the study. It was still pretty low at 36% correct identification in this method. All right, so that brings us now to our second set of cases. We're now going to switch gears and talk just about methicillin resistance and susceptibility testing in Staph aureus. So I'm sure we've all come across several situations in which Some of our test methods don't match, and we'll have a few cases to discuss that and some learning points around it. Okay, so our first case in situation 2 is a 38-year-old female with a rare congenital disorder and heart defects. She was admitted for replacement of her mitral valve. She suffered a prolonged and complicated hospital course, at which point she had a bronchoalveolar lavage, or BAL, obtained for workup of pneumonia that seemed to have developed in the hospital. On that BAL routine culture, we had this happen. On first day, we saw Staph aureus and performed PBP2A lateral flow test on the colony, and it was negative. So we had a presumptive report of MSSA on the culture. However, on day 2, our full susceptibility panel demonstrated MRSA. And so we did an investigation, and this, for a day there, we had what we consider a very major error, calling susceptibility, where there was resistance in the isolate. And our investigation showed that most likely, speaking with the bench techs who were involved in the case, that the PBP2A lateral flow test was performed on a single colony rather than how we would do susceptibility testing, picking, 5 colonies for Staph aureus tests. So in the end, we obviously had to have a corrected result of MRSA as well as some other corrective actions. So one of the things we, of course, will look at, and I looked at, was any patient harm as a result of this very major error. What we found was, fortunately, the patient was terminal, was do not resuscitate, was not being given a lot of additional interventions, and was kept on vancomycin just empirically, kind of end-of-life care. And she ended up expiring from a GI bleed, not related to the pneumonia or workup, but for pneumonia with our culture. Okay, and the other piece of corrective action was taking a look at our assay procedure for the PBP2A colony test. I don't believe we have this explicitly marked in our procedure, but now that we had this case happen early on, we made sure to add a little bit of verbiage here underlined that when we do the test, we make sure to sample at least 5 different colonies of Staph aureus, as we would for any susceptibility testing for Staph aureus, try to minimize the impact of possible heteroresistance. Okay, so that was that case. Now we have a slightly different situation. We have a 28-year-old male with chronic sinusitis. Ethmoid sinus tissue specimen was obtained for cultures. And this is what happened. On the first day, we grew Staph aureus. The PBP2A was performed on the colonies, positive. MRSA was reported. Day 2, though, we noticed, that was actually mixed growth of Staph epi and Staph aureus. And when you do the susceptibilities for those separately, the Staph epi was methicillin resistant, but the Staph aureus was methicillin susceptible. And I understand this does happen in many laboratories. So our investigation did confirm what we suspected, which was that the PBP2A was performed on young colonies, insufficiently mature colonies, so that we didn't actually know for sure on day 1 that we had pure Staph aureus. So the corrective action was to re-educate staff. They are much more careful these days not to try to prematurely perform a PBP2A, but to be sure that the colonies have had time to develop, beta hemolysis and color and all the rest, so that we could be sure that it's performed on pure growth and not really young growth. So we're trying to be a little bit more conservative there and draw a fine line. So that does happen time to time if we're not careful. Now we have another case in our series, a different problem with methicillin resistance testing in Staph aureus. We have a 71-year-old male who had knee pain after getting a total knee replacement or arthroplasty, completed a course of cefuroxime for this knee pain in case it was due to infection, was not getting better, and had to undergo a revision knee replacement. So at that time of the revision, knee tissue was submitted for routine cultures, and we isolated Staph aureus. Okay, so that's Staph aureus. The discordance here came with the susceptibility testing on the Staph aureus. The oxacillin on the Vitek AST card was resistant, greater than or equal to 4. And the cefoxitin was negative. The screen was negative. So we have a discordance there. And giving you the rest of the data, the PBP2A was negative, and the MEC-A completely off-label, but for investigative purposes, this was the only MEC-A test we had available in the lab. We ran it on the Verigene, and that was negative. So what we're seeing here is an isolated bump up in the MIC into the resistant zone for oxacillin, but all the other indicators for methicillin resistance in Staph aureus were negative. Okay, so we confirmed, as just part of any sort of discordant investigation, we repeated and confirmed all the results. We ran the oxacillin on a second test method, the e-test, and that confirmed with an exact MIC of 16. And then the cefoxitin by Kirby and by gradient diffusion strip were also susceptible, as confirming the Vitek AST result. Okay, so now we definitely have confirmed discordance. And what do? I'll show you in a little bit. The CLSI M100 has very valuable guidance to do in this case. I also just reviewed the literature to better understand what are the possible mechanisms to explain discordance in such cases. So there's a couple described here, and I have a more complete table coming up in a little bit. But one possibility that went through my head was, what does MEC-C look like? What's that supposed to look like? But that is supposed to be a different protein encoded than MEC-A, still giving methicillin resistance, but just a different, slightly different penicillin binding protein. So the PBP2A would be negative. And that one usually gives us a different pattern with the cefoxitin more prone to be resistant and the oxacillin prone to be susceptible on MIC testing. And then I found something that was called BORSA, or borderline oxacillin resistant Staph aureus. And these are Staph aureus that have an elevated MIC to oxacillin. So anywhere from 2, which is the upper end of susceptible, to 16. Cefoxitin can be susceptible, and you would expect the PBP2A and MEC-A to be negative because the mechanism for this increase in oxacillin MIC is not that. It's going to be a variety of different mechanisms that can contribute to this borderline oxacillin resistant. Excuse me. Okay, so of the many mechanisms described and discovered, some are mentioned here. Hyperproduction of beta-lactamase has been found in some BORSAs. Point mutations, truncations of expression of the penicillin binding protein of Staph aureus, or other genes controlling that have also been described. So it seems like it's a variety of different adaptive genetic changes that Staph aureus can develop to be a little bit more resistant to oxacillin. Okay, so in this case, it was a bit trickier. I came up with verbiage for cases like this that could be used as a canned comment in future, infrequent cases where we see possible BORSA. Just mentioning in the report that the isolate is resistant to oxacillin, but lacks a MEC-A-mediated mechanism of resistance based on additional testing. And then acknowledging and educating providers that other mechanisms are known to rarely occur in Staph aureus clinical isolates causing this oxacillin-resistant phenotype. Okay, so as far as treatment goes for BORSA cases, it's interesting in that studies have found when the oxacillin MIC is 4 or more, kind of in keeping with the breakpoint interpretations, that isolate is going to be more prone to not respond to penicillinase-resistant penicillin, so anti-cephaloccoccal penicillin treatments. So it is a good idea to avoid those when the MIC is 4 or higher for oxacillin, which was the case for this patient. Okay, so advising the infectious diseases provider, we agreed to stay away from the cephalosporins and beta-lactams and they changed the patient from cefazolin with rifampin to vancomycin and rifampin therapy. Okay, and finally, we have another case, our final case here for susceptibility testing for methicillin and Staph aureus, 30-year-old female with lupus and end-stage renal disease, presents with fever and now found to have Staphylococcus aureus endocarditis with septic emboli. So the Staph aureus seeded various areas of her body from being flicked off the heart valve. So our blood cultures isolated Staph aureus. The Verigene molecular panel identified Staph aureus with the MEC-A gene detected the day of the positive flag, giving us MRSA in the report. The PBP2A confirmed the colonies to be PBP2A positive. However, we had VITEC results from the subcultured colonies that were discordant from our PBP2A and MEC-A results. We had oxacillin of 0.5 MIC, which is susceptible, and the cefoxitin screen was negative. Okay, so certainly in our investigation, we wanted to repeat all the results, and the Viragene and PBP2A repeated as original. However, we did some additional look at the oxacillin testing, and we had a very, very experienced bench technologist working this case up, and she got the very cagey idea of testing the oxacillin from a different area of the plate, a different quadrant, with a little thicker growth, better sampling of the different colonies, and tested it by e-test and found that it was indeed all the way up resistant for oxacillin with an MIC of 256. So our only conclusion after all this investigative testing was this might have been a heteroresistance somehow when we tested the VITEC and the first time, that we did not capture enough colonies that were expressing resistance to oxacillin or cefoxitin. Okay, so now I want to just get into a little bit of learning points here. Number one is that there's really good guidance. One is especially published in the CLSI M100 Appendix H. And it goes through a lot of scenarios in which the molecular assay for resistance detection is concordant or discordant with phenotypic tests. And for MRSA, that's just one of the many organisms that's covered in Appendix H. So here's just a sample of the table that's found for Staph aureus, and you can see that they go over the various possibilities of test results for PBP2A and cefoxitin, and then the investigative actions should you have a discordant pair of results. And so generally speaking, you want to confirm the organism identification, make sure it's a pure culture. You want to repeat the discordant test results. And if you have at your disposal a MEC-A test, that could be very helpful as well. And in the end, after this, more or less complicated information on the tables is processed, I think it's safe to say you just want to err on the side of caution, avoid calling susceptible when there might be resistance present. Okay, so how often can we expect to find discordance in these various test results for methicillin testing in Staph aureus? Okay, so I put together this table, just did a little, mini literature review, and we mentioned MEC-C and Borsa already, and then there's also something called oxacillin susceptible MRSA. Okay, so for MEC-C, mechanism of resistance, it's a different gene from MEC-A, so the MEC-A analysis should be negative, and the PBP2A expression of the MEC-A gene would be also expected to be negative. As I mentioned before, the cefoxitin susceptibility tends to be resistant for the MEC-C mechanism, whereas the oxacillin testing tends to be susceptible. So if you see that pattern, it can suggest MEC-C. However, just keep in mind, it is relatively uncommon, the least common of the three in this table. So less than 1% of Staph aureus in clinical microbiology labs. With the Borsa mechanism, as mentioned, this is not a MEC-A driven mechanism either. This is MEC-A and PBP2A should be negative. Cefoxitin usually susceptible, but can be resistant in various studies. And then the oxacillin MIC, again, roughly defined as between 2 and 16 for Borsas. And this has occurred in roughly 5% of Staph aureus isolates when research studies have looked at this. And then finally, there's something called oxacillin susceptible MRSA. And these are the Staph aureus that harbor the MEC-A gene, but the oxacillin testing doesn't seem to reflect that, and it's susceptible. So you have this discordance. Anyway, so if the organism harbors the gene, generally we are very wary about reporting it as susceptible when we know that genetic mechanisms can get turned on and when an organism is subjected to that selective pressure. So anyway, in this situation, do recognize that this can occur, and we do see this, from time to time, that kind of discordance as well. Estimated incidence is about 5% of MSSAs turn out to harbor the MECA gene. Okay, so in the end, I think the key points are here that we should have multiple methods for detection of methicillin resistance for staph in a clinical laboratory. I think more information gives us a better picture. Otherwise, we might be missing expression of resistance in Staph aureus. I think it's important. I think most people would think it's important to have both cefoxitin and oxacillin for susceptibility testing of Staphylococcus based on the mechanisms we've discussed just now. And then always remember to test the PBP2A on, I would say 5 colonies if you can, pure growth of Staph aureus. As I showed you in the table, it's fair to expect some variation and discordance amongst the various methods for Staph aureus testing, and just be prepared on how to deal with that. And in your discordance analysis, definitely you want to make sure you have a pure isolate, the identification is accurate, the repeat testing confirms original results, and if not, then you have a better set of results to go with. But if you do confirm the discordant results, err on the side of caution so we're not making a very major error for the patient. Okay, great. And we have one final case to go through. I think it's a really fun case because it incorporates all aspects of pathology into one specimen. So here we have a 66-year-old male, has a history of metastatic renal cell carcinoma with metastases to the adrenal glands, the hip bone, and ethmoid sinuses in the past. And so much so that he's had 3 debulking surgeries of the metastases to his sinuses in the recent past. And now he presents with altered mental status. Imaging of the head by both CT and MRI demonstrated right frontal lobe abscess in the brain and sinus abscess versus metastases. And so you can see here in the maxillary sinuses here on the right side, it is filled with something that shouldn't be there, a mass, and the clinical differential was abscess versus metastatic disease as he's had in the past to the sinuses. Okay, so they went in and debulked this material out and sent us sinus tissue for fungal culture as well as for routine culture. So I'll show you the fungal culture results first. Came out beautifully for Aspergillus niger, didn't take long to grow. And then on the routine bacterial cultures, we also had some positive findings. The direct gram stain had 2+ polymorphonuclear or neutrophils, 4+ gram-positive bacilli, and 4+ gram-positive cocci. So this tells us we're in an area of inflammation and it's teeming with bacterial organisms. Cultures the next day fortunately recovered the GPRs and the GPCs. So we had 4+ MRSA undoubtedly there. And then we had 4+ diphtheroids, these coroniform organisms that on our first attempt for MALDI identification had no identification. And just, the question mark here on the bench side was, should we continue doing the workup? How far do we go? If we can't identify it, do we want to send it out, et cetera? So that question's kind of hanging up in the air. And let me show you some intervening findings. So in the meantime, I was sent the case for evaluation, see if we can confirm what we see under the microscope on the histology. So this is the H&E, very, very low power of the sinus tissue. And you could see that the bodies seen here are extremely large. On low power, these are occupying a lot of space. And so they definitely, to the microbiologist's eye, look like Aspergillus heads. And you can even appreciate all these dark round bodies here. Those are pigmented conidia. So all that is very consistent with Aspergillus niger that we isolated in culture. And here's a silver stain to give us a little bit better outline of the fungal bodies we were seeing on the H&E. So the black silver stain highlights the fungal elements, and here we have almost a nice profile view of the Aspergillus head with the conidiophore going into the vesicle and the radiate arrangement of the phyla. It's all consistent with Aspergillus niger. What's interesting, though, is the tissue gram stain as well. This, again, is on histopathology. And you can see here there's debris, there's dead stuff, and then some neutrophils. And all of these dark purple specks are bacteria. And it's very hard to get the oil photomicrograph to show clearly. So bear with me. There are definitely cocci, definitely a lot of cocci of it, that you can see clearly. And then there were also some bacilli that I will admit the pictures don't really show very well. I mean, I don't know if you can appreciate any possible palisading, maybe some elongation of forms, some V shapes. And I know it's very hard for me to convince people on this really unclear photomicrograph that they were gram-positive bacilli. But I will say, when I was examining this very carefully, I believe I could make them out. Okay, so here we have the continuation of the routine culture workup. In the meantime, infectious disease providers actually contacted the laboratory and really wanted to know, what was that 4+ diphtheroid? Are you guys going to work it up? Can you do susceptibility testing? And so we attempted it a second time, and it turned out to be 4+ Corynebacterium JKM, 99.9% confidence. And we were able to set up the e-test panel. I'll show you the results here. So as expected for JKM, it's very resistant to penicillin and susceptible to vancomycin. So for the clinical team, their diagnosis was more specific now to rhinocerebral, bacterial, and Aspergillus infection. And thanks to all the collaboration and good work on the laboratory and pathology side, the therapy was tailored to the patient. Vancomycin, which would cover MRSA and the Corynebacterium JKM beautifully, and then the voriconazole for the Aspergillus niger infection. Okay, so just a little bit of discussion here surrounding the sinus specimens. We do struggle with some of our mixed workups on sinus specimens in the laboratory, I will admit. So just took a little dive into polymicrobial cultures in these cases. Okay, so from sinus specimens, we have a lot of difficulties with the organisms we'll encounter. For example, Staph aureus can either be a colonizer or cause disease, kind of depends on the situation of the patient. Diphtheroids, we don't work up routinely in many cases at all, right? Especially in a mixed culture situation, we would hardly ever work up a diphtheroid, especially if it's considered to be usual flora in that area. But for this patient, you know, the Staph and Corynebacterium, this is a very interesting combination in the sinuses. From research studies, we know that these are the most abundant microorganisms in the sinonasal mucosa, whether it's studied in the healthy individual or in an individual with sinusitis. And indeed, chronic sinusitis, it can be a polymicrobial process in which you have a shift towards a bit more Staphylococcus and Corynebacterium and less of the other variety of species seen. So in the end, the polymicrobial nature of a sinus specimen may not actually be definitive for just, you know, contamination or colonization. It could still represent disease. So in our patient, especially in our patient who'd been in and out of the hospital, probably that's where they got these nosocomial pathogens, MRSA and JKM, and who's had prior operations done in that region, I think that really does put them at risk for a polymicrobial infection of the sinuses. And so in these cases, it's sometimes helpful to think of a sinus workup less as a respiratory specimen workup, but more as a wound culture workup. And then with the input from pathology, the histopathology demonstrating inflammation with the organisms right there in the sinus tissue, that would definitely prompt concern that these organisms are real from the culture. So to summarize those points, histopathology can be incredibly helpful in establishing the relationship of the organism that we see on histopath to the host tissue. There we can say if there's invasion of the host tissue, if there's an abscess, and if it's just superficial fungus ball type of thing. So it really helps to establish the pathogenicity of the microorganisms, especially if we isolate them in the corresponding cultures. Our gram stain from the culture, the direct gram stain, confirmed the presence of mixed organisms with neutrophils directly from the specimen. So that was very helpful. And then our cultures were able to confirm identification of those microorganisms definitively and give us susceptibility test results that help direct the antibacterial therapy in this case. Okay. So thank you for listening to these cases. I hope that we were able to reach all those learning goals and objectives. To summarize, identification of haystack organisms, which we discussed in the first two cases. It can be challenging, but the accuracy and turnaround time are improved with MALDI-TOF, and it really does help us to get to the appropriate susceptibility testing method faster. And then we reviewed a series of cases of methicillin testing discordance in Staph aureus. And I hope that we learned that we'll see for sure occasional discordance between all the various methods for testing MRSA. And use of existing guidelines can be very helpful to resolve most of our discordant issues. And then finally, commensal organisms can still cause polymicrobial infections, as we saw with the last case. And therefore, sometimes our workup does require a little bit more judgment, also input from the clinical team and the providers in order to get the best results for the patient and get them ID and susceptibility results when indicated. And great, with that, I'd like to thank you again for your attention to this talk. And if you have any questions, please, I welcome them all. Please contact me about this webinar should you require further clarification. Thank you.